Welcome to Cardiology Grand Rounds. It's my real pleasure to introduce Dr. Andrew Trister, who is currently the Deputy Director of Digital Health and Innovation at the Bill and Melinda Gates Foundation here in town. Dr. Trister has a long connection with Seattle, but did his MD PhD at Penn, and at I don't want to date you, but I think you were doing computer science and AI and bioengineering and its interaction with health quite early. It's now obviously become very important, but Andrew was one of the first in that space. He did internal medicine and then radiation oncology residency and was the chief radiation oncology resident at Penn. When he graduated, his career took a little bit of a left turn after, I believe, a short stint as a clinician, and he went to work for Apple in their one of their special projects groups, and at that time was really on the forefront of using smartphones as a way to diagnose and help monitor disease. And there was a number of really interesting papers on how to use smartphones to sort of diagnose and track patients with Parkinsonism and their course. And managed to do such a great job down at Apple that he was recruited to the Gates Foundation back in 2019. And we were just chatting. He came in, was able to, get his desk organized, and then the Gates Foundation shut down for COVID. So has been remote ever since. I was just looking, and they have at least one sort of really interesting sort of publication about using this technology in the COVID age. But really, this was a invitation because I think the things he is doing are so innovative. It overlaps with many of your interest in global health, and I think there were some real opportunities for collaboration. So Dr. Trister is going to talk to us this morning about consumer electronics and healthcare pitfalls and promises. Thank you again, Andrew, for joining us.
Thank you. And so nice to be here, even if virtual. I was thinking how nice it would have been to cross the Portage Bay this morning and actually see you in person, but hopefully we'll be able to get to that soon. So just as you heard, my role now at the Gates Foundation is largely focused on ways to bring digital tools to those in low resource settings. But I thought today, rather than talk about the current work, which has been very focused on COVID, I'd be able to actually rewind the clock a little bit and share some of my own journey, both through the training at UW and eventually at Apple, and to talk about some of the issues that you may be facing now as patients start to adopt a lot of these consumer electronics that are making claims, many of them FDA cleared, regarding their utility in cardiovascular health. And so let me see if I can, I do have a disclosure that as mentioned, I was employed by Apple. I still hold shares, which is part of my compensation. I will be talking about projects that I led while I was there. So the learning objectives of this session are to understand a bit of the technology underlying remote monitoring and screening for arrhythmias, primarily in this case, the Apple Watch and photopleth, and then discuss the current limitations of these types of technologies for healthcare delivery, which is more of an open discussion period. So I welcome you all to kind of come off mute and we can have a discussion. But I'd like to begin really with one of the things that led to that left turn in my career to join Apple. This was while I was still in residency training. As many of you know, at the Fred Hutch, there's a very active bone marrow transplant unit. And I had the opportunity to meet this family. This is a photo of the Frohmeyer family, circa 1980s, as you can probably tell from the haircuts. But I had a chance to work with them as a resident and eventually as a postdoc because two of their daughters, shown here, Katie and Kirsten, were both diagnosed with Fanconi anemia. And Fanconi anemia is an exceedingly rare condition, one of those conditions where there are more people studying the disease than actually have it in the country. There are about 800 researchers and about 100 known cases. And but it has a very, very long history in understanding the effects of radiation and DNA damage repair mechanisms. So many of the genes that we understand that repair DNA double-strand breaks are named after Fanconi anemia, the Fanc family of genes. And many of those genes were discovered because this family, when it happened that Dr. Frohmeyer was actually the dean of Oregon State University, he went out and found other researchers and other children that had this condition when his two daughters were diagnosed, and began the Fanconi Anemia Research Fund. And it was through their organizing and advocacy that they found ways to both donate specimens, to drive research agendas with donations. And a lot of the early 90s, early 2000s discoveries were because the families were very well oriented to what the research should do. And in the discussions with this family and with other families within the research community, really began to understand the role that patients can play, not just as subjects in research, but truly as equals. And so as I was leaving residency and thinking through ways that I might want to make my own impact, started to look at ways that were available at the time, this is about 7 years ago, to approach health tracking. And so you could recognize some of these things don't exist anymore, like a Health Vault. Some of them are the scourge of our practice, like Epic, and then others don't really play the role that they used to. But fundamentally, there was this concept that you could either have billable procedures as the sources of truth, you could have patients as advocates for themselves, just like with patients like me or 23andMe, although those companies started to monetize the data that they were collecting. There were efforts that have since closed, like Health Vault for Microsoft, although there's a reemergence of these same technologies again at Google and Microsoft. And then there were ideas of patient communities to market segments, such as Inspire and MedHelp. But our goal at the time was to build a medical information commons. And the concept here was that you could have this tripartite relationship between doctors, citizens before they become patients, and researchers, and try to find a way that information and questions can be shared equally across them. And ideally, this led to what we called Bridge, which was a funding that came from Robert Johnson Foundation and was the first of the academic funds that I had when leaving residency. But the concept here was to build a technical interface that allowed people to really advocate for themselves, to donate information, and to drive research in a different direction. I start here with this patient-oriented approach because really at the core of everything that I'll talk about for the rest of the talk, it really comes back to the same idea that patients at the center is a really laudable goal, but sometimes our understanding of the way that these technologies might impact our way to provide care, or certainly the way that we do research, may be slightly behind. So these slides I pulled from a talk that I gave in, I think, 2014, right after the Robert Johnson Foundation funding. And it just so happened that in the background of all of this, and just as you heard, my own experiences in trying to leverage what I guess we call AI now, machine learning technologies, were these kinds of headlines, which, some of these are even more recent, but the concept that we have a lot of hype around robots and AI, and that it's going to be the end of jobs as we know it because of automation. And then, of course, there's the more general, concerns, proponents such as Elon Musk and others who've been thinking about this, that there's going to actually be an apocalypse that is driven if we are not careful with these new technologies. So these two things together, the ability of building an information commons and having increasing data and the ability to use that data for various purposes, nefarious or otherwise, are exactly what coalesced. And so at the Brigham in 2015, there was this very large session that you can see here from the Brigham Bulletin on the left, where it pulled one quote where the CMIO at the time, Adam Landman, talked about the need for real clinical trials to validate the way that wearable sensors in particular say what they're measuring, and the need to determine what the value is in the clinical setting. The truth is that despite the fact that regulators like FDA have moved forward in this space cautiously since that time, there still is not a very robust sense of how to do this. And I had a different view in that same meeting, where clinicians really don't know what to do with things like step count. And so we have to be able to move beyond the things that we can know and validate and actually understand what the clinical implications are. But not surprisingly, the trends over the last couple of years and projection to the future are that there are millions of adults in the US alone that are using wearables. Many of them have all sorts of different kinds of capacity to make measurements of physiology. And this is only going to increase. And my sense is that the other part of that quote that I cut out was the fact that I had patients, even during residency, that were coming with Excel sheets of their Fitbit data. And I had absolutely no idea what to do with it. And I thought it was interesting, but the reality was that, whether somebody dropped off from 10,000 steps to 8,000 steps, I didn't know if that was a meaningful difference for them or not during treatment. I didn't know if there was some action that I should take. And so now here we are in a position where the ability to monitor continuously using some of these tools is becoming ubiquitous. People are choosing to buy these devices for various reasons. And yet how this can impact our care is still an open question. But I come back to a quote from Albert Einstein, right? Future medicine will be the medicine of frequencies. And I think here we're starting to see this tipping point of understanding the way that statistics and AI and the data that we're able to obtain are going to push us into what this new future medicine could look like. So all of that project that I showed from Bridge with the Robert Johnson Foundation funding, that talk was part of a talk at Stanford. And it just so happened that in the audience was a physician that was previously the chief medical officer at Masimo, pulse oximeter company, who was just hired at Apple to help with the secret project, the Apple Watch. And so we started talking afterwards, and his thought was, why are you building this on the web? We think that this might make more sense to engage with patient-generated data directly from devices like a smartphone or a wearable, and that we might have a framework in order to conduct research studies. That was quite intriguing. We again, it was a foundation-funded effort. There was a lot of connections with communities that we were anticipating, like the Fanconi Anemia Research Fund, but hadn't really thought about the way to engage with large populations of people. And so it shifted to start working on that infrastructure while still here in Seattle. And in March of 2015, this is a screenshot from one of the Apple events. This is Jeff Williams, the COO of the company, presenting to the world the work that we had done, which we called ResearchKit. Here's the icon, very Apple-y right there. So the software framework made specifically for medical research. And the concepts behind it were really embraced within 5 studies that we had designed to take advantage of the sensors that were on smartphones at the time. So there were studies that we had in Parkinson's disease and breast cancer survivors, looking at diabetes, cardiovascular disease, and asthma, trying to engage with people on a really lightweight way. But thanks to the fact that many people focus on some of these advertisements, hour-long advertisements that Apple does, we had tens of thousands of people showing up for clinical research who had never participated before. And so one of the studies that was the closest to understanding the longitudinal nature of measurements both passive and somewhat active. Right, passive meaning just carry your phone or wear a watch, and we'll record using the sensor stack what is going on and try to make heads or tails of what that might mean clinically. And then active meaning ask the person to do something slightly different. And so Empower was the study that we had sponsored from here in Seattle that was leveraging this ResearchKit framework and launched that same day in March. And these here we had about 12,000 consented participants, and ask them to perform various tasks like tap on the screen as quickly as they can, alternating fingers, record their voice, walk with the phone in their pocket, stand still for 30 seconds, holding the phone against their chest, and do a memory task. All cardinal symptoms of a movement disorder like Parkinson's disease. And the concept was that we could do some feature engineering from the sensors that were engaged in each of those tasks and start to understand how somebody with the condition, in this case with Parkinson's, might look compared to people that were age-matched controls who had also enrolled in the study. But the more interesting analysis that we performed on this data had more to do with the longitudinal nature of the data that we could obtain in this way. So it's very lightweight engagement. And looking at those people with Parkinson's on medications and trying to understand how was the physiological measurements we were able to make, in this case, the movement, speed, tapping, or hypophonia with their voice, related to the medications they were taking. And we found that there was, in fact, a very clear distinction between those people with Parkinson's and not Parkinson's. That should not be a surprise. People perform quite well and are restricted quite well when they're not restricted with Parkinson's, and become restricted with Parkinson's. And that's across most of the features obtained from walking and voice and balance. But the tapping was here shown on the top, the most separable between the two. But more intriguing was this concept of looking at the people as their own control. So longitudinally understanding, is there one or two of these particular things that they were able to do that distinguish this person's reaction to the medication that they're on? They were all on levodopa, carbidopa combinations, but so clinically they look the same. But could we now use this as a different lens to understand something different about their disease? And unexpectedly, what we found were that there were different categories. There were people who fluctuated extremely over the course of the day, going on and off, as the patients themselves describe this, states that they're in. There are those people, of course, that don't fluctuate. And then there are those who just didn't participate in the study sufficiently using those particular active tasks. It turned out that tapping for 30 seconds on the screen was almost like a game and enjoyable for most people, strangely enjoyable. So we got many, many more recordings of tapping than we did of taking a 6-minute walk. And so in this heat map, what we're showing is that using the tapping data, what we find are that there are people who have a certain category of speed with which they can tap on or off medication that relates, maybe in some cases predicts the way that they may have a feature in another thing, like in voice, right? So here on the very bottom of the heat map in the middle, we show features that were derived from voice. And so these things were correlated or anti-correlated in interesting ways. And so as a consequence, what we're finding are that there are those people who have predominant retardation in their motor versus those people who have hypophonia as the primary feature that we can measure. And this is the first time that we were seeing that there were differences of what levodopa can correct within the symptomatology of this condition that for 200 years had been basically one large umbrella disease. So it's with this that we found these data. I very naively perhaps had expected that because we had just burned through my entire grant funding that was the beginning of my academic career, I went back to Apple and asked them, thank you so much for amplifying the work that we're doing. This is amazing. We think that we can actually run a clinical study using some of these parameters that we're exploring here, trying to understand ways that we can interface with the clinician's assessment of what is going on for people, and maybe do that remotely even, but still use the phone and maybe even the watch at this point, which had just launched that same day, as ResearchKit. And it would be a small study. It'd be about $1 million, and we could do this with a dozen patients or so. And I was persistent. Every week I was there for about 3 months trying to talk to the executives and convince them that this was a good idea. But Apple, as many of you realize, is not a grant-making organization, and they had other ideas in mind. So rather than offer me the opportunity to do this from an academic post, it turned into an opportunity to lead clinical research for a newly formed team within Apple on health. And so that was an opportunity that totally came out of left field, and but the thought, maybe it would be worthwhile trying this out. So what I did have an opportunity to do when arriving there was to learn about some of the efforts that the teams had undertaken for future components within the device. And so here again is Jeff Williams now introducing the Apple Watch Series 4. And this in particular had a number of features that were quite interesting. And so I want to go into some of the technology that's underlying this, because it comes back to this idea of being able to do longitudinal recordings, but it has this strange implication when it comes to the clinical validity or utility of these measurements. And so on the back of an Apple Watch, if you've seen this before, is a laser diode here. This is showing the green diode, but actually there are two different diodes. There's a near infrared, which is on very frequently during the course of the day, that gives kind of a baseline heart rate that is reported back to the user. And then a very high energy laser, this green, which if you turn it on, basically wastes the battery very quickly. And so the concept was that this provides an optical detection of pulse waveforms in the capillary bed underneath the wrist. And from the very beginning, from the original Apple Watch Series 0, when it was launched, the concept behind including this kind of optical heart rate measurement in a near continuous fashion using the near infrared, and then in a beat to beat, very high fidelity way using the green during certain conditions. The concept behind it really came down to not so much we want to understand what your heart rate is at a baseline, although there are important elements related to that for wellness, but it really was in looking at the landscape of other wearable trackers like the Fitbit at the time. Many of them were using accelerometry as the main source of measurement for something that people could contemplate, like calorie output in exercise. And so the experience for most consumers, as Apple is a very consumer-oriented organization, was not a great one when all you really had was a jiggle meter sitting on your wrist. If you go for a run, that maybe is fine, and the mapping of how much you jiggled the thing on your wrist while you're running and how much calorie output that equates to, given other things like your weight and height, that could be that's simple math. But it turns out that for many of the executives actually at Apple that tried this out, they like to run on a treadmill or to use an elliptical or stationary bike in a facility, and you would be pumping your legs really hard on the stationary bike or even on a real bike, and not getting a lot of signal off of the accelerometer on your wrist. And so one way to make a more accurate calorimetric estimate of output is to include heart rate. And so the green laser was meant to give a very high fidelity heart rate during times of exercise. And so there was a feature on the Apple Watch that would put it into exercise mode, which was meant to measure, among other things, how long you were running or doing, other kinds of exercise. And there's always, with every new series of watch, there's an extension of what exercises it can detect. But but fundamentally, the heart rate was quite important. But of course, the engineers, not surprisingly, were saying, if we have this high fidelity pulse measurement, is there something else that we might be able to detect? And so the question that they had posed to themselves was detection of pulse irregularity using this high fidelity measurement. And so this concept, here shown on the top is something called a tachogram. So these are the pulse waves as reported back from that optical sensor. It's meant to be a periodic and opportunistic measurement because, again, that particular laser is very high cost from a battery perspective to run all the time with current battery technology. That might change over time. So this becomes a bit of a stochastic measurement where it will, when a person is still, the algorithm will turn on the green LED for a minute and get this very high fidelity measurement beat to beat. And then if there were something that was suggestive for atrial fibrillation, it will repeat those measurements more frequently. And so that's what's represented here by the blue and orange dots in the timeline. And the question was, how many repeated measurements were necessary before you would want to take an action for the person? In this case, notify the wearer of the watch, hey, there's something going on with you, you probably should do something. And if there were not a confirmation of that suggestive for a fib, in this case, after the repeated measurements, then there would be no notification, and that would just get logged, and the next day starts again, effectively. So it's completely opportunistic, longitudinal, and stochastic in its measurement. And when this was presented internally, there were many, many questions about this, as you can imagine. And a lot of those questions related to how well does this work? And that, of course, needed a large clinical study. But there were other questions too, which I'll get to later, which we still haven't answered. And so here, this was the genesis for what we called at the time the Apple Heart Study. This is a study that was the co-PIs were at Stanford, so just down the road from our offices, but all of the study design and the entire technology was developed with our team. So here, the concept was to evaluate the ability of this type of pulse notification algorithm that was, again, opportunistic, stochastic in time, to identify people that have true atrial fibrillation and then guide subsequent clinical evaluation. So we were measuring things like, what is the burden of notifications to people? Did they have a subsequent AFib diagnosis after they had a notification? How well does the algorithm perform, as I mentioned? And then typical things that would be necessary for any regulated product like safety. And one of the interesting bits is, just like with ResearchKit, where we had tens of thousands of people participating in these studies, we wanted to understand how large an audience we're able to address using these kinds of tools. So as a prospective single-arm open-labeled study, we included anyone over the age of 22 inclusive in the US that had a previous version of the watch, because as I mentioned, that launch was already FDA approved. So this was series 1 through 3, where we could install this software as part of the research study and have it run in the background in the way that I had described. And anyone that has a known condition already, if atrial fibrillation, atrial flutter, or were on anticoagulants in general, we decided to exclude the latter largely because, for unknown purposes or reasons that they might be on anticoagulation, including potentially that they had AFib, but unknown diagnosis now. So the concept was, run the algorithm. If there's a notification, notify the person and connect and ask them to connect to a telehealth physician who would run through a sequence of research questions. This was provided by Amwell. If indeed they were symptomatic at the time, send them to urgent or emergency care. Otherwise, mail an ECG patch, in this case a Zio patch, and have them wear that concurrent with continued recordings, and then discuss the results. And every single person ended up with an end of study survey. 90 days post completion. So the primary endpoint was to find people who had greater than 30-second runs of AFib on the ECG patch in the cohort over 65 who had come. And then ideally that we would be able to see simultaneously that the watch was detecting AFib at the same time as the patch. The ideal, of course, would be that there would be a notification, and then wanted to understand secondarily how many people actually went to the health provider after notification. So it was, as I mentioned, a single arm study. We thought that this was powered at about 500,000 people, and we had this assumption of 500 patches. And this was meant to yield AFib on subsequent ECG patch with a 97% confidence interval and a PPV, which was really the primary endpoint, because this was more of a screening element in those people over the age of 65, that again would be 97.5%, with a pretty tight confidence interval. So these were all comers coming in. We didn't reach the 500,000 mark, but came pretty close. But of the very, very large cohort, only under 25,000 of those were age 65 or older. And people were enrolled from 2017 through 2018. And then the last data collection was in 2019. That was the 90-day survey. So you can see here that the vast majority of people did not have any notification during the study period, not surprisingly, again, because I'll show you some of the demographics on the next slide. But of those that did have notification, I just want to highlight the fact that only 44% completed the first study visit. And this has implications with respect to how people might be perceiving the value of these kinds of tools in general, not only on a study, but I think, with respect to even bringing this to the attention of their physician, but that also vastly underpowered the ability to talk about how concordant was the measurement using this PPG on the back of the watch and an ECG that was, then sent to the people. And so you can see that this, because these were all comers and they were required to have an iPhone and an Apple Watch Series 1, 2, or 3, again, not surprisingly, this skewed quite young and skewed toward the, vast majority were white. And so these results, of course, take with a grain of salt. You can see here other risk factors that we would consider, primarily CHA2DS2-VASc. Here, of those people that were notified and had and even obtained the ECG patch, a higher percentage of them had greater CHA2DS2-VASc scores, but the rest of these numbers did not meet statistical significance in any difference. So here you can see one of the breakdowns again across age and sex with respect to the proportion notified in the total cohort. And notice, not surprisingly, that as one would expect, that the number of notifications moves exponentially as you get into the proportionally into the older cohort within the population. And that has implications for the follow-on study, which I'll talk about at the very end of the talk. And so, again, the actual AFib yield on the ECG patch matched with age. And so we were able to then look at the positive predictive values and calculated that, primary endpoint, remember, was positive predictive value for this particular irregular tachygram for an ECG confirmation of AFib in those over 65. It had a PPV of 0.6. So it didn't meet the goal that we had, but overall, for those people that did have the notification, specifically this confirmatory, 5 suggestive of AFib confirmatory pulse notifications within 24 hours, which is a much smaller subset within the study. PPVs overall did reach 0.84. So it seemed as though, as a screening tool, this could very well have been of some utility. That was the suggestion here. The other interesting thing is that when we looked at the AFib burden, again, because this is an asymptomatic population with no known history of AFib or other irregular heart rate, while I was actually quite surprised that what we found on the ECG, when we found people that did have AFib, it was 153 out of 450, right? So 30% of them, but 90% of those had duration runs of an hour or greater when we confirmed with the patch. And who knows what to do with the other 10%, right? What does a 30-second or a 6-minute component of AFib really mean? And this was one of these, and I know that this is still a very, very dynamic literature. I have not stayed as close to it now that I've come to the Gates Foundation, but this is one of the areas where I think here, those of you interested in electrophysiology and in general in atrial fibrillation and anticoagulation, I did do a quick literature review just to see what the updates were on AFib burden. I know that the debates have been on both ends, right? Like, this could be horrible to have a very low burden periodic, or it doesn't mean anything. So take all of that with a grain of salt. I still find it fascinating, and perhaps it goes back to the fact that we had to do this stochastic sampling over time, that we'd end up trending toward those people, not just that had these really short bursts of AFib, but in fact that we were finding people that were in more not quite sustained, but longer runs. And so at the 90-day survey, we found that even though there was an exclusion criterion, if nobody should have been included that had AFib, that we found out that 15% of people that returned the 90-day survey, in fact, had AFib before the study enrollment, which is unfortunate. And then about only 50% contacted a non-study provider during the thing. So adverse events were pretty limited related to the app. Of course, when you look at any cohort this large, you'll find something. And then in a follow-on paper that was just published, I think 2 or 3 weeks ago, there was a reanalysis of that same data, now looking not just for AFib, which was that was meant for the regulatory filing for FDA, but now is looking at any irregular pulse using that same smartwatch. And so these are, sorry, I didn't put the results. My apologies. So at any rate, not surprisingly, there are other sources of irregular rates that can be detected in this way, simply because the algorithm was not trained on AFib specifically. It was simply looking at the differences in the tachogram and looking for something that was irregular. So the limitations of the study, just as I had highlighted, had high drop-off after notification. There were fewer patches than planned, and it relied heavily on the self-assessment for the enrollment criteria, which caused these particular issues. I see that there was a question in the chat, so let me just pause here and I'll answer that. And if there are other questions, please feel free to put them in the chat, or you can just come off mute and ask. So the question is the Gates Foundation working on AI applications of focused bedside echocardiography? So this is a great question. The Gates Foundation has a strategy that relates to ultrasound in general, and primarily for antenatal care and for lung ultrasound for pneumonia, possibly even for tuberculosis screening. We have been, my team has funded an AI application that guides a novice user to do focused bedside echo. There's a company called Caption Health, so they are a grantee of ours, that has an FDA cleared tool that's a guidance algorithm using only the images that are off the probe. And recently they have gone through an exclusive licensing agreement with the Butterfly IQ. So if you've seen those point of care ultrasounds, which is another grantee, the Butterfly device actually was an equity investment of the Gates Foundation as well. So those devices use the compute power on iPhone. They're porting that to Android, and then Caption Health algorithms will be running basically as a GPS, if you will, telling people when to turn the probe, when to do substernal or suprasternal views, etc. So that work, while we're not funding directly the AI application for Echo, I do think that the go-to-market strategy for any ultrasound device in low and middle income countries should also include echocardiography as one of the use cases. Right now, as I mentioned, our main focus has been on finding ways to do the same thing for antenatal care and for lung. Hopefully that answers that. So another question here. Athletes and coaches have a long history of using wearable devices to improve athletic performance. I was curious if you partner with athletes and coaches to gain insights on how they collect, analyze, and utilize data from wearable devices to improve performance, and if you can translate some of their learnings to patient care. That's a fantastic question. So I think that this is a very open question. There's actually, right now, today, USC has a team called the Body Computing Center, and they are having their annual meeting. It's an 8-hour symposium, and the USC, all things aside from things like Varsity Blues, they have a long history of doing exactly this from the research perspective, and ways to translate measurements that are from various wearable devices into clinical paradigms. They've been working primarily with DARPA and the US military, so it's not exactly athletes, but they have data from people that go to Parris Island, so new Marine recruits, all the way to Navy SEALs during their very grueling training. Those devices can't be used in the field for various reasons, not the least of which is security. But there is a very, very intriguing potential for the ability of measuring different physiological parameters using that type of wearable. And these are still consumer devices, incidentally. These are not bespoke, longer range things that could predict fatigue. It could predict other kinds of illness. In fact, I think DARPA had a fascinating study that was looking at the ability of wearables to predict things like flu. And in fact, at the very top, we had repeated that for COVID just while we were here at the Gates Foundation. And then there are two other questions. So for the Apple Heart study, did the watch algorithm use high fidelity laser at a higher frequency compared to a normal watch wearer? It did. And although now, because we became FDA cleared, that feature is something that all people can turn on. It's turned on by default for people over the age of 65, and as an option for those people buying, this is for Series 4 and newer, buying a watch now for under 65, you can choose to turn it on if you so desired. And is there a follow-up study planned for underway with recent versions after the ECG feature is introduced for either AFib or other arrhythmias? Yes, and that's a fantastic segue, because that's precisely the other study I wanted to highlight. So as I mentioned, there were a number of limitations on the Apple Heart study in this format, and particularly we were very interested in finding ways that we might be able to augment the cohort that was at highest risk, so those people over the age of 65. And fortunately, because of the way that the health system works in the US, those people tend to be on Medicare or Medicare Advantage plans. And so this page is a copy of the Heartline study, which is a co-sponsored by Apple and Johnson & Johnson. And the concept here is that instead of simply having an experience where a person is going about their daily lives wearing a watch, doing whatever they want with it, and then suddenly they get out of nowhere we used to joke about it, like a quote unquote "have a nice day" notification. It's like, congratulations, you might have AFib, have a nice day, and just dropping people off with that information. The concept here was to both encourage people wearing the watch for a longer period of time, so that there was a higher likelihood that you would be able to have those stochastic algorithms run while the person is sitting still and wearing the watch over the course of a day, and also take advantage of the fact that in a population that has a higher prevalence background, that we may be able to take an action. The PPV would be stronger potentially, and we would have them close the loop. So rather than that 44% of people that actually connected with a telemedicine physician, that they could actually take an action on their own. Of course, a company like Janssen would be interested in potentially getting some of those people on anticoagulation, although that wasn't absolutely not one of the things that was part of the study. This is really meant to just understand the clinical care paradigm. And so this study has a different construct. There's actually a series of, I would say, educational material together with the AHA and Janssen that come together so that people have challenges to basically wear the watch. They are incented to do so by having the watch paid off. So for those over the age of 65 can enroll in this study, cannot have to pay anything for the Apple Watch if they wear it for 12 hours a day or longer. And it so happens that there is a tool on the watch that measures effectively wear time. It's called the stand ring. If you have an Apple Watch, there are 3 rings, right? There's a heart rate ring, there's exercise, calorimetric, and then there's a stand ring, which is stand up for 1 minute every hour for 12 hours. And so in order to achieve that one, you basically have to wear the watch for 12 hours. So it's a very, very lightweight experience for people. There was a lot of debate in IRBs to understand, are you coercing people or not with respect to this? But this study launched actually it was February of 2020. So 1 month before COVID became a global pandemic. And despite that, or maybe because of that, I'm not certain, it turns out that the enrollment has advanced very, very quickly in this study among those over 65. And though I can't share much of the research because I'm not part of the study team anymore, what I have learned from some of my colleagues is that anecdotally, what was before this 44% or so of people that were going to close the loop and speak to a physician has reached over 95% in the earliest cohort. So people, either because of the education or because this is an older population or because of COVID, who knows the cause. But it does turn out that the more people are taking the notification from the watch and trying to speak to their physicians. And so the study design here is, again, people with no history of atrial fibrillation who don't own a watch are randomized to have a watch or have standard of care. And then they have an adherence program, as I was describing, which is the stand ring, or if they have AFib, or they just have standard of care. And then this is a passive follow-up after the 2-year study period to see hard outcomes that are going on. And then there is a sense that, and this one is an interesting one. So again, it comes back to clinical care paradigm. Is it possible to improve patient adherence to an anticoagulant if you have a known existing atrial fibrillation case and you now had a measurement like that on the Apple Watch to inform that the person remains in atrial fibrillation? So that's the question. This is still using the passive measurements. I didn't answer the question with respect to the ECG feature because we had initially anticipated having a component where we would have the screening component, with the PPG, and then ask people to close the loop with an ECG. And so that's one of the features that right now is being studied in this Janssen design, where the ECG feature basically is an active thing where people have to, do a single lead loop by touching the crown on the watch. And in order to do that, the idea is the notification is no longer call your doctor. The notification says, take an ECG and let's confirm what's going on with you. So we'll see whether that has some implications. So is Apple still enrolling new patients in the Heartline study? I believe that it's still open to enrollment, although I probably should go and double check that. And then let's see, some other questions right before the discussion. These are great, so thanks so much for putting these here. Are there any data on predicting sudden cardiac death? So that one, not that I'm aware of. I think that that's a really difficult outcome to evaluate. So that might be a really hard one to get to. But there is an interest, and again, using a number of these different devices, not just the Apple Watch. Fitbit has a number of features like this as well as the Y things. They look at things like hard falls, and so there may be an opportunity to do a combination of knowing something a priori that might be a prior for something like sudden cardiac death, and then making these measurements if somebody had a hard fall and evaluating what's going on with them there. And then one final question.
Andrew,
Yes.
Before you leave that question, is there any work using the ECG data to look at heart rate variability, which might be what NOSM is getting to use heart rate variability as a predictor of events?
Oh, got it. Yes. So heart rate variability has been an area of tremendous interest for a number of these different wearable devices. And so increasingly heart rate variability has been linked for, again, it's largely in the wellness space is where most people are reporting it back. But I do think if it would not be unreasonable to imagine being able to run a study. Again, it would require a very large cohort if you're looking at sudden cardiac death, but making measurements routinely of HRV, and again, as I say, I think a number of the different devices do that today. Even other wearable devices like the Oura Ring and Y things and so forth.
All right, there's another question in the chat for you if you.
Yes, yeah. So this other question is, this approach is interesting, but it comes across as technology driven rather than medical need driven. Absolutely, totally agree. So what is the problem you're trying to solve? What are the alternative approaches? Why is this approach the best? And what is the likelihood you will be able to detect an impact on a key endpoint? I'd like to see these questions addressed. Yeah, thanks so much for that, because I do think that this is at the core of my so what slide here. So as I said, these were absolutely technology driven, and for many reasons, I would say that we should take all of this, if I were to wear my clinical hat for a moment, with a huge grain of salt, largely because of that. It's a measurement of convenience, if you will, right? As I mentioned, the heart rate measurement was done for use in a consumer electronics device for something like a calorimetric. It doesn't mean that it was meant to necessarily augment and certainly not replace a medical measurement or assessment. And so in that context, I think that there is still a lot of really interesting open research questions that relate to what does AFib burden really look like in the population, and can we understand more about how this condition of effectively of risk, physiological measurements can make a difference with respect to outcomes for people. I still think that that's an open question, but I don't know whether there is a clear clinical action. I don't think that any of these studies have addressed that yet. I think the Heartline study absolutely is getting to one set of endpoints, but I think that this is one of these very strange things that happens with innovations and the technology driven approaches in medicine. And I'll say, for my own field in radiation oncology, there were adoptions of technologies that, some people thought that they were on the bleeding edge, and others took 20 years of, very, very careful study. And it depends on what your own gestalt and thinking are, and then what the preponderance of the data show, in my sense of like how you would individually want to include or not these kinds of data in your own clinical practice. But I think that as a field, it is helpful, not that I can, proclaim anything with respect to cardiology, but I would say that in general, as a health system and as practitioners, that it is incumbent upon us to still pay attention to what it is that our patients are asking about, what they're potentially going to do for themselves, and how we might be able to guide them appropriately. In many ways, I think that is where we can help to guide what the research looks like, right? And not just wait for large tech companies or pharma companies to necessarily do what they think is right. And that comes back full circle to where I started, which was with the story of the Frohlmeyers, because I think that our patients, and I say this broadly, but certainly people in general want to participate. They want to learn more about themselves. I think they want to help others with conditions, and I believe that in many ways, finding ways to retain agency for the individual, ways that we might be able to provide them access to research questions and to participate in research problems, I think is one of the ways that we can take an action before we have this. There are a lot of questions with respect right now. I think we have seen, the manifestations of what has been a very long systemic bias with respect to access to care and understanding of conditions and people who have been historically underrepresented in clinical studies. And COVID is no different, but this is true across the board. I think that technologies, one of the reasons I've been very bullish about a lot of these tools, separate from those that I described today, have been that we can address exactly those disparities and bias, but we have to be mindful of them. And I think we absolutely need to approach it in a way that allows us to overcome what would be a natural thing. So I think that I hope that this didn't come across as me proselytizing for Apple. I know that is absolutely a potential. I think instead what I was hoping to get across is a set of questions that remain, and perhaps a way that we might be able to answer some of those. And as I say, I think that it's really incumbent upon all of us to participate more in research and potentially drive some of these answers if we can. I don't know if that answers your question, David.
Andrew, there's a few questions left. We're not going to have time for all of them, but I'm going to combine a couple of them together. And that had to do about these type of applications in your new role now at the Gates Foundation, which is, the Apple Watch is primarily used in industrialized countries and young populations. The initial studies had a very low representation of more elderly patients who are really the highest at risk and where most of the disease burden is. So maybe tell us about, the acceptance of these technologies in elderly populations. What are the options, and what are you proposing to use in those populations, but also in potentially some of the global health applications? And maybe that'll be our last question, putting you on the spot.
Terrific. Yeah, no, it's thank you for combining them all. So I think with the elderly population, what we have seen is that a series of additional features of these devices, the whole concept of aging in place, of being able, I'm in this cohort, right? So I have a young child at home and I have elderly parents across the country. Like what we, at least in high income countries, we absolutely are seeing a wish for the sandwich generation to be able to monitor their parents, but not have to live with them, right? That's happening in Europe as well, which is a very societal changing element. And so these types of tools become a remote monitoring ability. Now, again, agency becomes a major question, but you could just watch that landscape, right? Best Buy buying first Great Call, right? The I fall and I can't get up company, all the way to now having, I think, 3 or 4 different tools that they are selling as bundled services that go on top of that, all meant to kind of, be around the house, make sure that somebody hasn't fallen, make sure that they're okay. Again, that's for wellness and aging in place. But I do think that is going to bleed very quickly into how do you do hospital at home, right? So discharge from a cardiac event, and now suddenly you have like a series of monitoring events at home to ensure that things are stable, and if not, to pull people back in. And systems like Kaiser and Geisinger have already been trialing things like that in the cardiac rehab space. I think that when it comes to global health, this is all way too far into high income countries and high cost devices. And so in the theory of the case that we are driving right now from the Gates Foundation, which, as I mentioned at the top, I wasn't, at the I had chosen to talk more about this previous work rather than the current work, but our entire thesis is that we can take advantage of the cadre of workers that exist in low and middle income countries who provide the majority of care. About 85% of care is done in community. So it's a community health worker focus where many of these people are not trained as nurses or physicians, even as nurse extenders. Many of them are high school educated and then given checklists to go through. So effectively they were like census taking, are there pregnant people in the home? Are there older people, diabetes, things like that. And if we can augment them to do more than just take a checklist, because now you have somebody who could ostensibly provide care in the community. One of the major things that is missing is the ability to do an objective measurement, right? So in the old, concept of like you take your subjective complaint, now what's the objective measurement that you might be able to do? So it goes back to the ability of using devices, maybe like the Apple Watch, but certainly like a smartphone with the sensors that are already embedded in them to make them work, to start to augment what would be a physical exam that somebody who has a rudimentary amount of medical training might be able to perform, and then help them go through a triage and decision step for what might be, the condition of most concern for, a child with a fever or an adult with, some new onset condition. So those are the approaches that we've been taking for global health. I think that in the old Wayne Gretzky, don't skate to where the puck is, skate to where the puck will be. Like that's absolutely where we think that these things are. We're triangulating toward, when in the world will these devices and these technologies get cheap enough so that they can become as ubiquitous in low and middle income countries as they are here. That's probably still a ways off. But in the meanwhile, why not still find ways that we might be able to impact the care that's delivered? And the way that we think we can do that is through these health workers. So thank you again for the opportunity to come and chat and the great questions. This is really lively.
Thank you, Andrew, and for coming and chatting with us. I hope we can have you back in the future. Clearly, this generated a lot of discussion. I hope we can have you visit and meet with some of the folks who raised questions, because they're also very interested in these issues. So thank you again, and to all who stayed online, have a good weekend.
Yeah, thank you. Take care,
Thanks.
everyone.